Good to go. 5 minutes early. So we're just going live on Facebook. I've hit record on Zoom. We'll just get them all going and then I'll get Instagram on. And the music carries on. Got some music this time. Okay. Okay, cool. So we're on Facebook, on Zoom, Brill, and on Instagram. How you doing? Pete, you all right? Hi, Abby, over on Insta. Good to see you guys. Just going to give it 5 more minutes. Let people log in. So obviously you've got my friend here. We're talking about wrists and stuff. Shimmy Helen. Hey, Kate. Sharon, how you doing? Danny. Good to see everyone. See everyone. This is how much we see each other these days, isn't it? Leanne, how you doing? Good to see you. Niall's in. How you doing, Niall? Okay, just turn that down a smidge. Got a bit of background music. Hi there, Wayne. Good to have you in. Sam, how you doing? Okay, so we're just, while people are logging in, we've got a couple of minutes. We usually go for up to an hour. So if you're on a lunch break, fantastic. If you are stuck at home, furloughed, not working, fantastic. If you're super busy, these are all going onto the Biomechanics Education YouTube channel. So if you've missed the previous ones, by the way, we've done these every week, all of lockdowns since last March. So, so there's a whole bunch of these chats. It's me, it's a monologue, for God's sake. I would much rather be in a classroom with all of you guys. So please do comment, share, send in questions. So this week we have 3 questions, kind of 3 questions. And hi Helen over on Facebook. Hiya. And Scott, how you doing? Squat I had in my head because I've got my squat bar out, Scott. In my head I've been squatting this morning. First time in ages. I'm going to have some serious DOMs tomorrow and the day after, I'm quite sure. Okay, so we've got 3 questions. We've got one about why massage is important, why my clients' wrists hurt when in prone kneeling in my Pilates class. We're also going to talk a bit about pain science. So there's not really a question around that, but there's a few things that I'd like to share from the little I know about pain science, from the reading I've done and the experience I've had with clients as well. So we'll kick off. So first of all, the question was from Marina as well. Hi Marina, wherever you are. I'm sure where she is on the social media, she'll be in here somewhere. She asked some really good questions. So why is massage important to us? It was the question. So I'll just let my assistant in. Come on in then. Why is massage important to us? So I am a trained manual therapist, but I don't use manual therapy techniques. I prefer my clients to rely on me more for biomechanics assessment and movement advice. And then I take advantage of my colleagues who are practicing manual therapy far more than I would, and are going to be far better skilled at it. When they need that, I refer them out. The little I know about massage was many, many years ago when I was trained, there was this whole talk about it improves, it flushes out toxins, and there's a whole bunch of stuff, and there's a lot of things being challenged today. So it isn't really my forte, but the little I know and the more modern concept around massage is about the neural response. But let's just pause for a minute to think about, why do you like massage? Why would you like massage? Now, my husband actually can't stand massage. but he's not a tactile, touchy-feely type person like me. And so from history, potentially, and from past experience. But most people, when you feel achy, sore or tender, what's your initial response if something hurts? It is to touch that area. So we know that there's a natural instinct for touching areas that are uncomfortable or sensitive or sore. You know, it's like that pressing a bruise sensation. So there's clearly a response. My understanding is, and again, this is my little understanding, so I'm happy for anyone out there to share, that there is a chemical response in terms of an endorphin response to it. So that neurotransmitter response from human contact and touch, you know, hugging, kissing, sex, all of these are human interactions where you have that skin-to-skin contact, and they give us emotional responses through chemical changes. So we kind of know that happens, but specifically massage, exactly what is it doing? I know that 30 years ago, the concept of what it was doing, it's kind of changed a bit now. And the idea that you can, I'm trying to use my words carefully because of when I've listened to my colleagues who know this subject far better than I do, the idea of what it actually mechanically does is being challenged. And the idea that it's more of a chemical or neurological response sits, yeah, me too, I love massage as well, Kim. But the idea of a neurological response, I think, makes more sense. And in terms of the way the body responds to neural stimulus, if you think of, and again, I like to strip it back to the simplest perspective, the body is a set of 3 subsystems, if we put it really simply: the myofascial, the skeletal, and the neural. The neural system is the software of the body. Your brain, which is the central nervous system, communicates with the rest of the body to decide how much muscle tone or what sensation to produce for whatever response. So the idea of massage affecting the neural system kind of makes sense. So the hypothesis is there's a neurotransmitter response that either creates a hormone response or a sensory, certainly a sensory response, obviously. But what actually goes on inside the body based on that, hi Nikki, it's a challenge to prove in terms of the science behind it, because the way we would test things, there could be a couple of things that change you in terms of being relaxed, the hands-on, exercise, movement, and so on and so forth. So I'm struggling to give a clear answer, and I think that might be because the research has changed, and I haven't read the research. But from what the little I do know, there is definitely a response to human touch. We're all missing that right now, right? Kim over on Instagram. I don't know if you've managed to get a massage, but you know, it's one of the things that I'm really keen to get when it's permitted. It's just a holistic, nice music, full body massage, bit of oil, smells nice, where I could just chill out for an hour. The mental, psychological, the relaxation response to that is for me, is my favourite. Then there's that sports massage response of maybe a more aggressive or tactical way of using hands-on approach, maybe with the same mechanical input idea of it being a neural response, but to get a biomechanical change. So that's the one where it's slightly more uncomfortable, maybe, where you're trying to maybe get the message, the neural message, in a different place or a different depth. But certainly I think the idea of the serotonin, that endorphin response, the chemical response, kind of makes sense to me. But I'm slightly uncomfortable on this subject because I don't have the research or the data. However, let me give you a great resource or a signpost towards Mike Grice of Movement Therapy Clinics and Education. So Movement Therapy Clinics is where he practices. He's got a clinic there. And Movement Therapy Education, if you put that into your internet search bar, He is not only a personal trainer, an osteopath, strength and conditioning coach, he's also an anatomist, a fabulous educator, and he will be able to give you a more scientific perspective. I know he's well read. So Stevie, with massage, all we are touching is the skin. So with all of the receptors there, something has to be going on. Is it the expectation of the client that drives the feeling? I think you've hit the nail on the head there, Stevie, that it's going to be different to different people. And you know, some people prefer a bit of an elbow in, others prefer that softer, oily sort of style of massage. And it really is a personal choice, I think. Mechanically, that's what's going on. I think we've got to be mindful of what we suggest or think it's doing. Am I right, Stevie? I know that you've been doing the training with Mike recently, so maybe you can share a bit more insight into that. But I think certainly the receptor neurotransmitter idea is probably where I come from. I think when you get back to the so what question, yeah, exactly. They expect it to be sore, therefore it is, yes. I'm going to talk about pain science in a moment as well, Stevie. So the original question, why is massage important for us? I think we've kind of talked about that in terms of just human contact, skin to skin. When you have a baby, the first instinct is to put skin on skin, and they certainly recommend that. Breastfeeding, the reproduction cycle of the idea of having sex, it's that skin to skin, it's very intimate. But then coming back to the massage idea, I think in a simplistic term, yes, that kind of receptor response. Skin can be very sensitive, and that's deliberate as a protection mechanism as well, which is what I'm going to talk about in pain, the pain science bit. But hopefully, Marina, that's kind of guided you a little bit. I think any of the manual therapists out there who want to share from a more educated perspective, I've only done sort of level 3 manual therapy. And as I said, I don't really use it. It's not really a skill I want to use, but I do like to know what's going on so I know when to refer a client. So probably, yes, more of a neural response. So I hope that's okay. The second question from Marina was about why many of my clients, myself included, complain about their wrists when they are on 4-point kneeling. So 4-point kneeling is when you are on all fours. The idea that the wrists ache. Do they just have weak wrists? They have not mentioned this in their PAR-Qs, and there isn't a question that says, do you have a weak wrist actually in a PAR-Q, to be fair to Marina on that one. If they do, how can they be strengthened, and what is going on anatomically to cause wrist aching during class? Okay, so this is probably something that most of you, if not all of you, have come across. Sam, I cannot diagnose, treat, or anything on Instagram, I'm afraid, my friend, but hopefully what I'm going to talk about now might give you insight into being able to explore. If you have, I think you mean carpal tunnel syndrome. If you do, you need to see a practitioner to get it diagnosed. If you've had it diagnosed, go back to your practitioner about what to do. Don't take what I'm saying as a diagnosis or a treatment, please. And I'm going to explain that as we go. So it's quite common for people to feel uncomfortable in wrists when they are kind of leaning their body weight on them. So why is that? Well, let's think about the questions first. What is in the wrist? And what is the difference? So here's a question for you, Marina. She joins us on Zoom now. Is if they were to extend the wrist and just extend the wrist in this position, does that hurt, or is it purely when there's weight on them? So that would then be indicative of it's not the movement, but it's the load or the force. So that's what I'm going to talk about, because that's effectively what's happening in that move, is there's a lot of load going through it. If we look at the wrist anatomically, a little bit like the foot, there's a lot of joint surfaces going on in here. And the wrist actually is made up of where you've got the hand or the cuboids. Coming down, you've got the radius. The ulna doesn't actually make up part of the wrist. It articulates with the radius. Sorry, let me do that over on Zoom. I'm on several platforms. So you've got the bones in there, you've got a lot of structures and surfaces. You've also got ligaments. There's a lot of ligaments in there. There are muscles in the forearm that control wrist movements. And then you've got 3 nerves. So you have a brachial plexus in your neck, which coming down the arm, you've got the median nerve, which comes through these 3 fingers. So if you imagine the fingers in the shape of the M, the median nerve. You've got the ulnar nerve, comes underneath. So imagine the last 2 fingers as the U of ulnar. And then the radial nerve comes down the back, somewhere around, I think, the mid-forearm or thereabouts. Now, my friend over on Instagram mentioned, I think it was carpal tunnel syndrome. So you have a carpal tunnel, obviously of bony landmarks, tunnel meaning like an opening or a pathway. And there are quite a lot, I think there's something, it's either 10 or 11 structures pass through the carpal tunnel. So what we're talking about in here are common issues that could present in the wrist. So first of all, we've done the anatomy. So what's in there? Well, there's a whole battery of stuff. Then if we think about lifestyle, and I don't know about the audience here, but just going back to maybe Marina's demographic in her sessions, and correct me if I'm wrong, Marina, but it might be kind of female of a certain age group, upper age group, so that we generally have a lower upper body strength than lower body strength. Generally, I think females in general do. Not all, but in general. But also if we're at a desk quite a bit, and then the wrist is kind of pressured and resting on a table, or you get them pressure mats to rest your hands on, that can actually press on where the neural pathway is as well. Nerves don't really like this. They weren't designed for this. They were designed for gripping and moving, and if you think back to us in hunter-gatherer days. So the lifestyle we're leading is creating a different environment for the structures within the wrist. So the body's trying to adapt, can't adapt quick enough. So we may experience things like repetitive strains or overuse issues, which can then result in things like carpal tunnel syndrome, where you get a thickening of the ligament, and so it closes that gap in the carpal tunnel, puts pressure on the nerve, creates things like bilateral pins and needles, or even on one side it can be more worse than the other. So it's also thinking about the actions at the wrist: flexion, extension, ab and adduction. And actually by 4-point kneeling on the wrist and then putting body weight in a force down through the wrist, body weight over the top, and then loading that. It's a relatively fragile structure in terms of the way it's designed. It's probably not designed for resting on and doing planks and so on and so forth. Maybe for crawling around, but again, it depends on what you're doing in class, Marina. But to come back to point, there can be a plethora of reasons as to why wrists ache. Number one, there's force going through it with an extended wrist. Just a basic, the force production. Why would some ache more than others? Could be their lifestyle, could be that they have already got some kind of, they may have arthritis, they may have tight median nerve, which then makes it ache a little bit. So not quite carpal tunnel, like a clinical condition, mechanical adaptation to shoulder compensations. Trying to think of my vocabulary very carefully here. That mean that there's a little bit of a grumble in here. There could be other issues like I was looking up to tendonitis. There could be other medical conditions going on. So I'm going to assume that they haven't been diagnosed based on Marina's question. So if they haven't got a medical diagnosis, then force and potentially a lifestyle adaptation that's just creating a slight complaint there. So the second part of the question is talking about, do they have weak wrists? If they do, how can they be strengthened? So because an area aches doesn't necessarily mean it's weak. It might do. The ache question is, well, why is it aching? So as you alluded to in your question, Marina, I want to go back to each individual client who said their wrists ache when they do that to clarify, number one, have you got arthritis? Have you got tendinitis? Have you ever been diagnosed with carpal tunnel? Can I just clarify? Because your regular PAR-Q is actually not really that extensive. So we're relying on our participants and clients to divulge anything outside of the PAR-Q. So I think what we need to be mindful of is the little information a PAR-Q asks for, and understand we need soft skills in questioning further should they start complaining of anything, and trying to work out. They might say, oh yeah, I've got to tell you, I had carpal tunnel a couple of years ago. Right, okay, carpal tunnel syndrome. Right, okay, so then there's a likelihood they may well have a biomechanical issue in the shoulder area that's creating tension on the median nerve, so that when they put force through the wrist and extend it and stretch the nerve, it's just aching and complaining a little bit. So understanding all of those things. Are the wrists just weak? I've no idea. And again, to strengthen a wrist, I mean, you can do wrist strengthening exercises, but I'm not sure that's the solution. It's understanding what you're doing in class, the relevance to the goal. Is there a way of adapting it? Should we adapt it? And who is the individual we're talking about? Because all of that information can change what we do about it. So Marina, you know me by now. I can't give you a direct answer to this question, but I wanted to talk around it to allow others who may have the same question to, like you, start to think about what can I do to help clients who in my classes say that their wrists hurt when we go into prone kneeling. So extensive PAR-Q, ask more questions, get clearance on all of that. If you're still not sure, get them a biomechanical assessment. Marina, I know you're doing the biomechanics coach diploma, so you could start that process for sure. Maybe take them off the wrists, trying them on knuckles, but then really they need to be able to put the palm flat. So it may be that even doing whatever you're doing in all four kneeling, can they do it against a wall, or can they do it in a slightly more raised surface so that the load going through the wrist isn't so exaggerated? Can they create a better base of support? So is it when they go on to a plank position, a full plank, which increases the force at the wrist? Or is it just when they're on 4-point kneeling, like Marina's example here? How can we reduce that? So it's understanding risk versus what we're trying to achieve and the individual. So I can't give a direct response, Marina, but I think you suspected that. Okay. We had a very quick chat about pectineus. I don't know if you wanted me to go into that anymore, Marina, but I think we kind of covered that one. So what I would like to talk about now, I think it was Karis actually, maybe, I can't remember, from last week, was asking me to talk about the pain science. Or just bear with me. Steve, I've seen it suggested that a towel under the hands changes the angle and may help. Yeah, thanks, Steve. I think that's what I was getting at with the different position, so that it's not so extended is what you mean, isn't it? So if they put a towel under the wrist, then there's less wrist extension, which might be another way. Thanks for that, Stevie. So there you go, Marina, that's another alternative. But I'd want to understand why they ache. It may just be aching through, they're loading it up, and it's perfectly fine. But I think you've got to take each participant individually, which is where Stevie's kind of offering us one suggestion. Oh, and Kim says you could fold the mat over, which would be a much easier kind of alternative, which is what you do. Yeah, thank you, that's brilliant. Thanks, Kim, and thanks, Stevie. Okay. So pain science, and by the way, I'm no expert, but I do deal with clients in pain, and there is a section within our Biomechanics Coach Diploma where we talk about it. The fitness industry has a level 4 low back pain qualification, which we teach within our Biomechanics Coach Diploma, and so we need to talk about it. We need to understand it better, and there are far better and more knowledgeable experts out there than me. So I'm going to guide you to them, and then I'm going to use some of their information combined with my colleague Mike Grice, who the osteopath I spoke about earlier, to just bring you some nuggets to have a think about. And then I'm going to send you to go and do some research of your own and let me know what you find out. So pain and our understanding of it is changing from where it was some time ago. And if you go and look at Lorimer Moseley or David Butler, they wrote, they've done a whole stack of research. They're neuroscientists, and they've written books. This is an audio, actually, it's just some CDs, but they've written a book called Explain Pain, which is great for both practitioner and client to understand. So I'm going to talk about information from this. And then more recently, they've done an upgrade, Explain Pain Supercharged. This is far more technical, and while I've got both, I do prefer the simpler version purely because it helps me show and communicate to a client more easily. So this is far more technical. Great book, by the way, but if you were going to invest in one, I would suggest the book that has this on the cover. I'm not sure what edition they're on. I think it might be 4 or 5, unless that's Trail Guide. I can't remember. But do check it out. I would suggest if you work with or live with pain, if you work with clients with pain, buy the book. Buy the book, and you can use some of the images in there to help communicate to clients about their pain. So if you remember when we talked about massage just earlier in this live, and we were talking about neuroreceptors and so on and so forth, pain is kind of on a similar wavelength. And what Lorimer Moseley and Dave Butler talk about is the idea that pain is good. Pain is normal, and pain is a very deliberate response to keep us safe and protect us. It's a signal. It's a warning to say, move away, it's hot, or take your foot off that nail, or whatever it is. So it's a normal response. So individuals who are born with a condition where they don't feel pain often don't live past the age of 40 because they don't recognise they have a problem going on. They don't sense danger when it comes to burning or scalding or hurting themselves, or even tumours and things growing inside them. So to understand the way pain works is important in helping clients who experience particularly chronic pain, I think is what we're talking about here. But I'm going to talk about the kind of difference as well. And acute pain is definitely a signal and an alarm to say, take your hand off the hot stove, move away, it's going to burn your skin. You've then got a kind of a mid-phase, but we're going to talk more about that chronic pain in this particular session, which is probably going to be more relevant to you and your clients. So number one, pain is normal. It's really important we let clients who experience chronic pain understand it's normal, it's good. It's just telling you, we need to do something. Let me help. Another thing that can happen when clients experience pain is they think the journey of recovery from maybe an injury originally is just a straight kind of swerve up a graph to feeling better. The pain will gradually just disappear. And often it isn't. It's often a kind of a road that goes all over the place. You have more pain, then less pain, then it's a weird pain, then it changes. And so coming back from injury can actually be a kind of a rocky road to recovery. It's never a straight line straight through. It is about gradual process, allowing the system to adjust and recognise the danger is no longer there. So that's what I want to talk about. It isn't always, certainly when it's chronic, it isn't always a damage indicator. So what I mean by that is, if you imagine, let's imagine stubbing your toe. Out of 10, 0 being no pain, 10 being literally making your eyes water like agony, where would a bad toe stub sit on the pain scale? It's going to be right up there in the 8, 9, 10, isn't it? It's going to be like, oh, it takes your breath away. And yet there's no pathology, there's no real damage. It's like a paper cut. You know, and even if I just talk about a paper cut in the middle of your fingers, and then most of you are probably, oh, you get that response. But the actual tissue damage is nominal. It's very, very small. There have been cases of individuals who have no pain but huge damage. There was a guy who managed to shoot himself in the back of the head with a nail gun. I think he'd been working up in a ceiling and dropped the gun, or it had fallen, and he literally shot a nail in the back of his head. He felt a kind of a bang, didn't think anything of it, took himself to a medic. He had a scan, and there was a nail literally in his head. But he had no pain, or it was, you know, he thought it was nothing. There's also talk about, you know, people with bullets that they, you know, they remembered 10, 20, 15 years ago, they felt something whiz past their head, and it didn't, it was a bullet, and it's still there in the back of the head, but they were fine. So this is where, you know, actually that's quite a serious damage, but no pain. The other example, the other end of the scale is, if an example would be an amputee and the phantom limb pain, where they get itchy or tingly or even a painful limb that is no longer present. They've had a leg amputated, or they've been in war and they've had it's been blown off, but they still have the sensation in a foot that's missing. So that sensitivity is almost over-stimulated, and the memory of the pathway is still happening, even though there's no limb there. So they're kind of two extreme examples. Chronic pain and hurting doesn't necessarily equal harm. It's about understanding it. And a persistent pain in particular is more about sensitivity. And so pain can be that kind of, it's trying to protect you, and it's got this memory of danger, but actually the danger is no longer there. And it might be that we need to use special techniques to help clients who experience chronic pain to understand their pain better, what's causing it, what could be causing it. That alone, their understanding alone, can actually desensitize the pathway or the neurotransmitting of that message. Pain can change a lot of functions within the body, you know, endocrine system, hormone response, all of these things. And again, sort of just touching back on the idea of massage and that idea of how it can change the way the body responds. We still know very little really about how our bodies function. We know really very little. A lot of what we know is hypothesis or subjective, and Lorimer Moseley and David Butler do a really good job of scientifically kind of almost showing us what would make logical sense to the way the body gives us pain, responds to pain, and so on. So if we have a pain that's there for a long time, it's chronic, you know, it's beyond the recovery time from some kind of injury, it can become amplified through that kind of mechanism, that fear mechanism. So people often say, well, is it in my head? And it's kind of, well, no, but yes, actually, because pain is an input, not an output. So what do I mean by that? Well, your tissue doesn't hurt, but the tissues are telling the brain to tell you to move your arm or not move your arm through the messaging and the receptors. So you always think where there's the damage, that's where the pain is, because that's the way the messaging works, because it's telling you to move that part of the body either away from danger or to make it feel better. But actually, we're trying to understand better the idea of the input of data, i.e. If you see something that looks really bad, that kind of sensation. I don't know if you ever watched a horror movie where, you know, you like a chainsaw chopping her arms off, and you almost get a physical response yourself just watching it and imagining what it would be like to have your arms. Am I really morbid? I'm just trying to think of examples for anybody out there to kind of give you examples of the way the body gives us pain, and almost that it's a deliberate response to help us move away, but actually we can feel it even when there's nothing wrong. So understanding how this can affect us emotionally, so certainly a horror movie will give you an emotional response. And then, Stevie's just reminded me of the guy who, was that a nail gun as well, I think? Yeah, nail gun, shot himself in the foot, screaming in agony, needed morphine. They got him to A&E, they cut his boot off, and the nail hadn't even broken the skin, it was between his toes. And yet the agony he felt, the brain message communicated from his visual response to seeing the gun go through his boot, gave him the sensation, and a very extreme sensation, to the point where they had to give him morphine. But then when they took the boot off, there was actually no pathology, there was no damage, there was no blood, there was no core. So trying to understand, well, what does this mean for our clients? So when you're working with a client who experiences pain, obviously, number one, pain is a red flag. However, once they've got cleared through the clinical aspect of making sure there's no injury, medical condition, tumour, broken bones, whatever system you need to put them through to stay within our scope of practice, if they then come back to us and the medics are kind of going, well, there's nothing there, I can't find anything, could it be a biomechanical issue and the tissues in the body are just grumbling because we're sitting too much? And any of you who has chronic low back pain, particularly for a long period of time, it can almost get worse and worse just purely because it's being amplified because you can't get rid of it. And particularly if somebody is saying to you, it's in your head, there's nothing wrong with you, crack on with life, and yet you hurt. Your pain is real. Your client's pain is real. So we need to be responsible for learning more about how pain works, the triggers of pain, contextualizing pain for clients. Once we've got them medically cleared, so if any of you are medics, we need your help. But if you're not a clinician, once we've got them cleared and they're okay for exercise, but they experience pain, how can we help them manage that? We need to educate them. There can be emotional changes to pain. So if any of you, like me, hear the word dentist, I had root canal treatment a couple of years ago. It was the most horrendous thing for me because she hit a nerve. I had about 6 lots of injection, and every time she went to drill, I could feel it. Now, whether that was real or whether it was in my head, I don't know. But now, dentists, my jaw starts to ache. But there's nothing wrong with my jaw. So it's understanding how that can affect us emotionally. Depression, mental health, and pain, we suspect, we know are interlinked. Understanding which one may come first is trickier. If somebody's had chronic pain, has that made them depressed? Or does the depression make them feel pain more? So, we know that there is a link, we just don't know necessarily the order they come in. But right now, this is super important. Mental health is declining, and for any of you who are interested, I've got a webinar on Friday morning all about mental health techniques, by the way. You can find it on on one of my pages. and we're going to be talking about mindfulness, mental health, mindset. I've got 3 experts in doing just a morning webinar, 3 sessions. They're the experts, but come along and enjoy some time with them to understand again how we can use techniques of the mind to make us feel better. And this is where the pain science sits in to our understanding. Stevie's talking about Greg Lemon's pain bucket is worth checking out to back up some of the stuff we're talking about here. Thanks, Stevie. Pete, I was admitted to hospital last Friday with lower back, went sending my whole body into muscle spasm, so much so I could, needed morphine. So there you go. So we've got somebody actually sort of sharing with us that they too went in. So I hope you're okay, Pete, by the way. It would be interesting to follow your progress. Let's stay in touch. And what did the medics find out? Did they scan you? Did they find anything? Or was it a case of there's nothing we can see on an MRI? So when we have this persistent pain, there is things that can, so within our system, persistent pain, the neurotagging, so the nerve kind of latching on, if you like, becomes more easily sensitized. So what that means is you feel pain more easily. Let's say, Pete, I don't know you, but like, you know, I know you're on social media. Let's say it was when you were digging the garden, you felt your back go, yeah? So the idea of forward flexing actually activates that neurotag to give you pain, even though there's nothing going wrong inside your body. It's just like a response to being bent over, which is where you hurt your back previously. That neurotag can actually then couple with other neurotags that are linked to emotion. And so our emotions, our beliefs, bending over, all of these things come together into the sort of like a coupling and makes the reporting of pain more easy and more sensitive. So that it's almost smudging the message, the true message of what's going on inside the body. So neurotags become more easily activated. They can link to emotion or belief. They become more easily activated, and it kind of smudges the reality of what's going on inside the body. This is where you can get odd sensations. They move around, they're a bit weird. You do get them, you don't get them, they intensify. Pete went to A&E for morphine, you know, and there may well be something going on inside your body, and that's where you go and get yourself cleared. Yeah, so he's having an X-ray and a physio session, fantastic. So once the clinical aspect is cleared, hopefully it is for you, Pete, then it's right, okay, what else can we do to help Pete's system understand the danger's gone? We're going to help you move better, get a more strong, robust body. And I know, Pete, from your social media, you look pretty robust and strong. So it would be interesting to understand mechanically what's going on, what the medics think. But our job as therapists and movement professionals is to help clients have confidence in movement. And if they have a belief that every time they bend over or dig the garden or sweep or hoover, no excuses, guys, is going to bring on their back pain, is that really the act of spine flexion, or is it a sensitive coupling, smudging of the neurotags within their intrinsic system? I hope that makes sense. Context as well. So Laura Mosley talks about the idea that a violinist will have super sensitive fingers if that's their profession. It shows on scanners that there's more of the brain lights up, is wired to the hand. I don't play the violin, by the way. Something like that, isn't it? So that those fingers, if they get damaged, you know, there is a greater response to that. So we can get this oversensitivity. It's really about breaking the cycle, understanding the clinical implication, getting them cleared, working with our allied healthcare professionals to better provide for our clients by ruling out the red flags, getting the clearance in a written document, so that when we work with them, we start to educate them and expose them to like a graded exposure to the activities, the sensations, to allow the system to calm down. And I'm talking about this is not acute pain where you need to see a medic. This is chronic, where it's almost like the medics are kind of scratching their head saying, well, there's nothing wrong, we can't find anything. Is that something that's from the past? So we can use our pain scale, 0 to 10, it's like an adaptive ball version. So 0, no pain, 10 having your arms ripped out of sockets, where are you? 3, 1 to 3, 0 to 3 or 4, low grade, okay, that could be within our scale. We should still get those guys cleared by a clinician, I believe. Somewhere between the 4 to 7 mark, be really careful. If it's anything above that, that is a major red flag. We need to get them checked out. Anywhere on this scale, I think they should go through a safety net online, a clinical clearance, through a clinician who can ask questions that I wouldn't know to ask as a strength and conditioning coach or a biomechanics coach. But what a clinician can do and ask those weird questions, I don't know what I don't know. So they can ask the questions that rule out anything sinister and they can send them back with some guidance. That's really where we as an industry should be. I'm talking about the exercise world, really. There are also myths around posture being linked to pain. And I'm not saying that certain postures can't cause pain, i.e. bending over, but bending over in itself shouldn't really cause pain. Like sitting. Sitting's fine. Sitting cross-legged is fine. Sitting over a computer like this is fine. There is nothing wrong with it. I've just done it. I've just done it. It's the lack of variability. So I've talked about this in a lot of these posts, these lives. It's more about keeping the body moving. And it's really important that we understand pain and the way it works, that if we're going to keep clients moving and they experience pain when they move, how do we, as movement practitioners, help them trust and be confident in their body to move even though they experience some level of discomfort? So primarily, get the clearance, get the referral, because pain is a red flag. Then it's understanding how to communicate to them from our perspective what's going on, maybe using resources like the Explained Pain book. Lorimer does, both Lorimer and David Butler, I've got some videos over on YouTube. If you're skint right now, which a lot of people are, just head on over to YouTube, put Lorimer Moseley in, Lorimer and he's quite funny and he's easy to listen to, so a load of his videos will come up. The idea that knee valgus means your knee will hurt is also not necessarily true. It might, but it also might not. So it's understanding the things that can trigger discomfort. There's a lot of talk as well now about reluctance for clients to see MRI scans because after the age of 20, I think it is, you're probably going to have bulges and dehydration and all sorts of things going on. But 85% of you will be asymptomatic. So a herniation and dehydration, normal kind of wear and tear, is not necessarily indicative of that is what's causing you pain. This is where sometimes the medical world, while brilliant, if they fail, could it be an oversensitization? The body just needs strengthening, a movement practitioner's input. This is where we want to try and bring the two worlds together so that we can help clients who experience pain, chronic pain, to have confidence in movement but stay within our remit and help them gradually expose the body to it and desensitize that system. So Kerry says, someone else has mentioned pain. Oh, right, okay. They mentioned pain as it's not my field. It's not my field, but if I think Kerry's keeping an open mind to the idea that you will have, I would imagine, in your client base, clients who experience pain. So I think we don't necessarily need a qualification. I think, I don't know, can you get a qualification in pain science? Sounds like a really heavy degree to me. But what we can do is understand better, get resources that we can then share with clients. And in my experience of working with clients who do experience long-term chronic pain, one of the most profound things we can do is purely educate them on the way it works. And that alone can actually start the process of bringing chronic pain levels, sensitivity to pain down. We know strengthening the body helps it to feel stronger, better, and less pain just from the act of doing that. We talked earlier about, in Marina's question, about the aching in the wrists. Could it be a weakness? We assume pain means weakness, and it's indicating something, but is it a weakness in the tissue, the structure? Is there something going wrong? Or is it a weakness in the system of messaging? And so trying to understand the definition of weakness is really important now. I've done that before in several of these lives. So I don't want to go on that too much, because you can go and watch those on the Biomechanics Education YouTube channel. So, anything else? So does that pose any more questions? Let's just have a little look. Who we've got in Zoom. Okay, over on Insta. How you doing, guys? Hi there, Joe. Hey, Joe. Getting better. Glad to hear it, Pete. So we've covered, I feel like we've covered loads today. Marina, what if when you have a condition that is chronic, that the pain isn't going to go away and it's just something you have to manage? Oh, Marina, you've just opened a can of worms. I have arthritis in my lumbar and it's painful every day. Okay. I haven't got long. This is a great example of, thanks for sharing that, by the way, of a situation where the belief is, that's it, I'm going to have pain for life. Is that the one thing that is maintaining the level of discomfort that individual feels? Now, what I'm aware of is you are talking about arthritis. However, I'm sure there are people with arthritis that don't have pain. But if the clinicians are saying to you, you have arthritis, you're going to have to live with that, and then you're attaching that emotion and the idea to pain. Now, I'm not saying that this is a solution, Marina. I'm trying to tread carefully in what I'm saying, but I'm aware of the broad audience. I would 100% be working with this type of client closely, long term, to understand their experience of pain, their understanding of pain, their understanding of what they've got going on inside their body, their ability to move, the movements that create pain or take it away or reduce it. And it would be a very long-term process of walking through to help with an understanding of the things that help or hinder. I think the assumption that it's for life will mean it will be for life. However, if we can train that client into some level of hope within reason, within a realistic scope, and then start to work towards things that we can do to improve movement, strength of movement, and maybe the sensation, that would be the direction I would take it. I'm aware of who this is, Marina. I'm just trying to talk around it. So if you want to have a conversation afterwards, we can do. But this is a perfect example of the way that statement is written is a condition that's chronic, it's not going to go away, so that's it. It's that almost the resigned hopelessness, and I understand that, I totally get it, but I think a big part of what we need to do is give individuals hope, support, and look at what has been done and what hasn't yet been done. Because it's quite likely there are things that haven't yet been tried, maybe. And again, once we eventually meet Marina, I'm sure we'll have some conversations around this. So I'm talking around it, but you understand where I'm coming from based on everything I've spoken about. Joe, yes, totally, 100%. Joe has just hit the nail on the head over on Instagram. Language is paramount. What you'll notice is I keep pausing and I try to choose my words very carefully. I feel like my brain works so much faster than my mouth, and I try and slow everything down to make sure what I'm saying is as clear as I can make it about subjectivity in these kind of subjects. Plus, I'm talking to a broad audience of people, 95% of whom I have no idea who you are, your background, or what you're thinking. So one of my friends over on Instagram who asked about carpal tunnel syndrome, how can I fix it? You know, I made it quite clear right from the beginning. I'm going to talk about some stuff. This is what I'm not saying, and then this is what I can say. So yeah, definitely, Joe, you're right. Sharon, clients that report crumbling spine because the doctor said, yeah, and again, this is where both sides of the industry of working with humans, so let's say the medical world over towards the exercise world, to kind of encompass what Sharon's saying here, we all need educating on a better means of communication and working together. We all need a safety net. We all need to trust each other. And there are some people I would trust more than others. It's usually the open-minded ones, or the more modern, the ones who do CPD basically, the ones who are more up to date. The old school idea of stripping out an IT band, and if it's bruised, you know, I mean, just all that kind of idea, the fact that, you know, pain is indicative of damage, and, you know, the old kind of idea of stuff. I think we need to try, and this is why CPD is so important. We've got to stay up to date. So even if you did, and all respect to anybody who's done a full-on degree in something, because I certainly haven't, the time it takes, you have every right to have pride in that 5-year commitment to all that education. However, if you did it 10 years ago, some of it could well be out of date. That's why CPD is so important, to just keep on top of the latest information and data. So Stevie's saying, yeah, a brilliant session for all of us. So important to stay within scope of practice, and correct use of language education is key, 100%. So I am, interestingly, with my physiotherapist and osteopath colleagues, designing an online safety net. So I've talked about the word safety net, and it does exactly what I've just said. It's all online. It is a system that brings us all together and protects every person involved. It will signpost the movement practitioner to a clinician who is trained to send their client back with guidance, and vice versa. All the data is protected. The client sees it, the physio sees it, the personal trainer sees it, the manual therapist sees it, the GP can see it. All protected and all within a system where the client's details are held, so that whoever they give permission to can see it, and it protects everyone. The training will also train the language of the clinician, the language of the exercise professional, the language of all the people, to be able to allow us to communicate. So yeah, we're really excited about it, Sharon. I've given you a little teaser there. It is at the moment in very early stages, but all of the big groups that we're speaking to have shown massive interest. I think it's a game changer, but I would, because I was one of the instigators. However, when it's ready, when there's a prototype and you can have a go, you tell me what you think, because we'll want your ideas on it anyway, so that we can improve it and create a solid system from it. Oh, you're very welcome, Helen. Shimmy Helen. I like the name. Does that mean you do this all the time? Every time I see your name, I want to do a shimmy, Helen. So I'm going to bring it to a close because I'm waffling now. The sun is shining, so make sure you get outside, use up your quota of exercise. Are we on a quota? I've got no idea. I haven't been watching the news, if I'm honest. Are we on a quota anymore? Thanks, Zoom. Deborah, Karen, Keris, Nikki, Caroline, and Helen. I think that's Helen. Comes up as feel good, so I'm assuming it is. Sharon, Looking forward to that squat seminar. Stevie, thanks for your input. And Joe, Shimmy, Helen, Melissa, Leanne, good to see you in. All the others, Pete, Rudy, I don't know who else is still in there. I'm just having a look. Jane, anybody else? Right, I'm going to close off. Send in your questions. Marina, thanks for yours. Always really, really good questions. I think everyone's enjoying them anyway, aren't they? Listen, have a good week. Look after yourselves and each other. If you want to come to the mental health webinar on Friday morning, ping me a message, check it out on the website, or it'll be on my social media feeds everywhere. I, for one, cannot wait. Take care, guys.